Thank you all for joining us today. I know we have a packed and wonderful agenda ahead of us. So I want to, first of all, welcome you all for joining today's Public Forum 2020 Foresight, Understanding Women's Eye Health and Supporting Patient Needs. I'm Katie Schubert. I'm President and CEO of the Society for Women's Health Research. SWHR is the thought leader in promoting research on biological sex differences in disease and improving women's health through science, policy, and education. SWHR science programs identify research gaps and address unmet needs in diseases and conditions that exclusively affect women or that disproportionately or differently affect women. Vision impairment is one of the most common causes of disability in the United States, and women are disproportionately affected by certain chronic and debilitating eye diseases across the lifespan. Today, we're pleased to have 4 distinguished panelists joining us to help us better understand the impact of eye diseases on women's health. We have Dr. Debra Schomburg, epidemiology and head of strategic and scientific affairs at Evadera PPD. Dr. Tren Green, who's a primary care physician and glaucoma patient advocate. Dr. Layla Lohman, who is a dentist and a thyroid eye disease patient advocate, and Kira Baldonado, who is Vice President of Public Health and Policy at Prevent Blindness. I'd like to also thank the sponsor of today's event, Horizon Therapeutics. And as always, we are live tweeting today's event. So I invite you all to join us and use the hashtag SWHR Talks Eye Health on social media. With that, I would like to introduce SWHR's Director of Science Programs, Dr. Irina Ninye, who will be moderating today's forum.
Thank you, Katie, and welcome everyone. More than 12 million Americans over the age of 40 are visually impaired or blind. Some diseases become increasingly common and burdensome with age, such as age-related macular degeneration, cataracts, and glaucoma. Up to 2/3 of Americans with these conditions are women. Other eye conditions that tend to occur as complications of an associated chronic disease, such as diabetic retinopathy and thyroid eye disease, are also more prevalent in women. These are just 5 brief examples of eye diseases that affect women disproportionately and differently than men due to biological sex differences and gender-based influences, affecting women not only as patients, but also as caregivers and sometimes as both. SWHR's Eye Health Program was established to raise awareness of sex and gender differences in women's eye health and disease, and to address research gaps and unmet needs in clinical care, education, and policy. We've assembled a working group of expert researchers, eye care providers, policy professionals, and patient advocates who are committed to improving care for women with these and other chronic eye diseases. With the guidance of these experts, SWHR has been developing a patient toolkit to increase awareness and understanding of women's eye health and help individuals with eye diseases and vision impairment better navigate their care. We're excited to launch this toolkit, a guide to women's eye health, in January 2022. Today, we have 4 members from our working group with us to give us a sneak peek at some of the content in the toolkit and to share outtakes from a closed roundtable meeting held earlier this month that discussed the health, social, and economic impacts of women's eye care and diseases, as well as some of their professional and personal insights on the topic. Following the speaker presentations, I'll be moderating a discussion with all of our panelists, so we invite you to use the Q&A box at the bottom of your screen to submit questions throughout the event. We'll start our panel of speakers with Dr. Debra Schomburg, who will speak about how eye diseases differently impact women and treatment approaches for long-term care management. Thank you for joining us, Dr. Schomburg.
Thanks, I appreciate the opportunity, and hello everyone. If we can go to the next slide, please. For about the past 2 decades, we've understood that women are actually disproportionately affected by eye diseases and by visual impairment and blindness. And this is actually a global phenomenon. While we're still trying to disentangle all the reasons for that, there are 3 things that we've highlighted here that account for some of the differences in why women are more likely to have eye disease compared to men. One is age. Women have a longer lifespan than men, typically in most countries, in the US included. And a lot of the diseases that cause visual impairment and blindness are age-related diseases. They get more common as we get older. The second thing is that women are also at higher risk for certain conditions that might have eye consequences. Things like autoimmune disease come to mind, and there are others that disproportionately affect women and then impact their vision. Another factor in terms of eye irritation and some types of eye infections are more common in women who use contact lenses or makeup, and women are more likely to use those devices and makeup as compared to men. In fact, 2 out of 3 contact lens wearers are women, and that might not be a big surprise to folks. Some of the age-related eye diseases, and these are the 3 most common causes of blindness and visual impairment. And those are age-related macular degeneration that affects the macula, or the very central part of your retina that's responsible for the fine detailed vision, things like reading, seeing faces, being able to read, and so forth. 65% of the cases of macular degeneration in the United States occur among women. We think this is primarily a result of the increased longevity of women, but there may be some biological differences that contribute as well. A second major cause of blindness and visual impairment is cataract, and that's when the lens, which is a little tissue that's about the size and shape of a plain M&M that sits behind the colored part of your eye. And with age, that lens can become cloudy and impact vision. 61% of all the cases of cataract in the United States also occur among women. The third disease that's common among women is glaucoma, and 67% of those cases occur in women. This is a disease that's characterized by damage to the optic nerve that impacts the peripheral vision long before impacting the central vision, so can cause problems with things like walking around, navigating through crowded rooms and spaces, walking up and down curbs, and crossing streets, etc. We can go to the next slide. Treatment and management of age-related eye diseases is of key importance to try to minimize the impact on vision. One of the most important things we can all do to try to prevent vision loss is to undergo routine and comprehensive eye exams. It's been estimated that about 3/4 of all blindness and visual impairment is either preventable or treatable with things we already know how to do. So it's really crucial for particularly things like glaucoma to receive an early diagnosis. And then for all those age-related diseases, monitoring of disease progression and early treatment has been associated with a maximization of the effectiveness of those treatments. There are also some things we can all do in terms of our lifestyle to impact our likelihood of getting those diseases in the first place. And one of the most important for eye diseases is cigarette smoking. And it's important to advise folks to not to smoke in the first place, or if folks are smoking, to quit smoking, which will have an impact on reduction of consequences of eye disease. Diet has also been linked to a number of age-related eye conditions, and it's important to eat a balanced diet and maintain a healthy weight. It's also important to avoid excessive ultraviolet light exposure by wearing sunglasses or hats. And this has been associated with cataract as well as potentially some other eye conditions. Some treatments for some age-related eye conditions include, for example, nutritional supplements that have been shown to impact the progression of age-related macular degeneration from its intermediate stages to the late stages of the disease. In some cases, injected medications are needed for the wet form of age-related macular degeneration. For example, a very effective treatment involves the injection of a medication into the back of the eye. Sometimes laser procedures are used in ophthalmology, and sometimes surgery. For example, with cataracts, surgical intervention for cataract is one of the most successful surgeries in medicine. For glaucoma, one of the really important factors in terms of maintaining vision is really about adherence to treatment, taking your eye drops. Glaucoma is usually managed primarily with eye drops, and it's very important in that condition to continue to adhere to the treatment recommended by your doctor. This is also true of, for example, injected medications for age-related macular degeneration. We can go to the next slide. Some other eye conditions that we wanted to highlight in today's discussion are diabetic retinopathy, which is a consequence of diabetes. And as most of you probably know, diabetes is really kind of a global pandemic at this stage with a growing number of cases of diabetes. And folks with diabetes have an increased risk of something called diabetic retinopathy, which is an impact of the vascular tissue in the back of the eye. There's a 2 to 2.5-fold increased risk of progression of disease during pregnancy, which is obviously something that impacts women in particular. Another important eye disease for women is thyroid eye disease, which is an autoimmune condition in which the body attacks healthy tissue in and around the eye. It can cause things like bulging eyes, dryness, a lot of irritation of the eyes, and other symptoms. This disease is 5 to 6 times more common in women than men. So really something that impacts women at a much higher degree than men. If we go to the next slide. Treatment and management of diabetic retinopathy and thyroid eye disease also includes some of the same features as we were talking about with the age-related eye diseases. We would emphasize the importance of routine comprehensive eye examinations, again, because early diagnosis and monitoring of disease progression is really the key toward maximizing treatment effectiveness. Management of the comorbid conditions, so the thyroid dysfunction or diabetes care. One of the primary drivers of diabetic retinopathy is the level of control of diabetes. So hemoglobin A1C levels are by far and away the strongest risk factor or driver of the development of diabetic retinopathy. So the underlying condition and management of that is important. This points to the need for strong communication across medical specialties, including primary care, endocrinologist, and your eye specialist. It's a coordination of care. It's an approach that involves the treatment of the whole patient, not just the eye. Treatments might include some types of lifestyle changes, again, injected medications, laser procedures, and surgery. If we go to the next slide. Thank you.
Thank you very much, Dr. Schomburg. I'd now like to introduce Dr. Tren Green to share her journey with glaucoma and how it tied into her passion for advocacy work in this space.
Hi, good morning, everyone. My name is Tren Green, and thank you for this opportunity to speak with you about my perspective on being a glaucoma patient. I am a mother of 3, a family medicine physician, and a glaucoma patient for the past 26 years. My eye health journey actually began at a very young age. I've been nearsighted since age 5. And so from a very early age, I realized the need to get routine eye exams. And in my childhood, I was doing very well. I really didn't have any particular eye issues until I hit senior year of high school. That was when I was diagnosed with a rare inflammatory condition called papillophlebitis. And in that condition, if it's not diagnosed promptly and treated accurately, you can lose your sharp vision. And so what was a very horrific occurrence was actually really serendipity, because what happened was, due to that condition, I came under the radar of a lot of different eye doctors in San Francisco, and they treated me very well, and I recovered my vision and was able to go off to college. While in college on the East Coast, I did not really have any discernible visual problems. And that is the bane of glaucoma. Glaucoma has a nickname. It's also called the sneak thief of sight, because it usually affects your peripheral vision first. And it's often can be very advanced at the time of diagnosis because you don't really have any symptoms early on. Fortunately, I was very lucky because I was still being monitored very closely for my previous inflammatory condition. My doctors realized that my eye pressures were rising. And so I finally received a glaucoma diagnosis at the age of 21 when I was graduating from college and headed to medical school. My first glaucoma specialist was someone I saw when I started medical school. And the early years after the diagnosis were really uneventful. I simply had to put in one eye drop in each eye every night and see him about every 3, maybe 4 months for a pressure check. And so the pressures were well controlled and I had no visual loss. However, glaucoma is not always so easily managed and the course can be different in different people. So for me, despite the fact that I was an otherwise young, healthy woman, glaucoma took a drastic turn. And it seemed as though at every milestone in my life, glaucoma reared its head and threw me a curveball. So I began to have vision loss for the first time when I was about 28, despite really well-controlled pressures. My glaucoma specialist opted to do a trabeculectomy to give me the best chance at lowering my eye pressures and preserving my vision in the long run. But the day before my trabeculectomy, I found out that I was pregnant with my first child. And that was unfortunate in that there were certain medications called anti-metabolites that were proposed for the surgery. They were used to reduce scarring in the eye, and those could not be used because I was pregnant. So the surgery was really suboptimal. And glaucoma runs its course differently for every person. For me, despite very close monitoring by an excellent glaucoma specialist, I have endured a lot of surgeries over the years and suffered vision loss. I have had 2 trabeculectomies, revisions to the trabeculectomies. I've had shunts, 2 Ahmed valves placed in the same eye, laser diode cyclophotocoagulation, and a corneal graft that was put in one eye to deal with the side effect of the Ahmed valve. I have lost about 60% vision in my left eye, and there is a small field vision deficit in my right eye. Fortunately, my central vision has remained intact, and I do not have very good depth perception anymore, and my night vision is terrible. So this leads me to the next part of what I want to talk about is that glaucoma can wreak havoc on your life, and the best way to manage it is to be adaptable and to be positive. My first glaucoma specialist told me that I would be blind by the age of 50, and that's something I definitely do not recommend saying to a patient. I remember being so frightened about the loss of independence, as well as not being able to be a productive person. And after crying over his comment in private, I resolved to prove him wrong and to adjust my life so that I could live it fully. And this leads me to comment on the mental health aspect of glaucoma. As I said, I was terrified by my diagnosis and could only think about all that I would lose. And glaucoma can easily lead to depression, especially if the diagnosis if it's diagnosed late and there's been significant vision loss, or if glaucoma ends up progressing very rapidly. Anxiety is common too, since glaucoma progression is not necessarily predictable. But the most important point to remember is that for the majority of patients, glaucoma is actually a slowly progressing disease. Most patients can live with it as a chronic illness, and vigilant collaboration with your eye doctors can preserve your sight to live a full life. The social impacts of glaucoma are varied. In the early stages, after your diagnosis, no one would probably be able to tell that you have a disability. But as the vision deteriorates, your perception is not as sharp. For instance, I cannot always see my neighbors' faces when I take a walk, and so I rely on their voices to identify them. My depth perception is also severely affected. So I'm more careful going down the stairs in my home. I can no longer do procedures at work, such as suturing. My night vision is terrible. So unless I am really familiar with the route, I don't drive at night. As a woman, glaucoma has even affected discussions regarding childbearing. For instance, there are medications that cannot be used to treat glaucoma, such as the prostaglandin analogs, because there's some fear that it can lead to cervical dilation, miscarriage. As I told you earlier, my first trabeculectomy, my first eye surgery was not optimal because there were medications that could not be used because I was pregnant. And I've had 3 cesarean sections because it was concern about increasing the eye pressure during pushing in natural labor. And even in our more enlightened times, women do shoulder most of the childcare burdens. So my glaucoma surgeries necessitated several weeks of recovery each, often involving minimal lifting. And that's very, very difficult to do while caring for infants or young children. As a chronic disease, glaucoma carries a strong financial burden. So one has to have frequent ophthalmology visits for pressure checks, visual field testing, and testing of the health of the optic nerve. The glaucoma medications are quite expensive. I'm currently using this particular kind, where 2.5 milliliters cost several $100s without insurance. Furthermore, faced with a sight-threatening illness, one may choose to have a less lucrative career that can be handled with diminished vision. And finally, if and when surgery is necessary, one usually cannot work for up to 6 weeks afterwards. And so that's a big loss of income for many people. So I've had a challenging life living with glaucoma, but feel hopeful and thankful. The most important support person besides your family should be your ophthalmologist, your eye doctor, because he or she is in this journey with you together and wants to see you do well. So never hesitate to ask questions at your visit, ask for a second opinion, or voice your fears with your doctor. Personally, I have also found meaningful volunteer work with the Glaucoma Research Foundation, which is based in San Francisco. It dispenses information about this disease, as well as fundraises to give research grants to scientists who are working on a cure for glaucoma. I also try to help out, such as in these speaking engagements, to educate others about glaucoma. And I like to donate to Guiding Eyes for the Blind, mainly because I have a real soft spot for dogs, but also because they do a wonderful job providing seeing eye dogs for people with visual disabilities. And finally, as a physician working with the immigrant Asian population, I see many patients with glaucoma, since Asian ethnicity is one of the risk factors for glaucoma. So I share my own story with them, and I try to take my time to encourage them to stay on top of their eye health. I want to leave you with this, that glaucoma is a chronic disease that one has to manage like high blood pressure and diabetes. It can come on at any time, not just with older age. And therefore, routine eye care is critical. And while there is always the fear of going blind, and there are multiple financial and social impacts from glaucoma, one can minimize disruptions in one's life by seeking care and being vigilant. Next slide, please. So I just want to leave you with this. I believe this will be also in the toolkits, but in preparing for your visits with your doctor, these are some questions to consider. Like, what can I expect during my eye examination? Do I need additional tests to diagnose my eye condition? How often should I schedule eye exams? In terms of ongoing treatment, what are some treatment options for this eye condition? What lifestyle changes should I undertake to try to slow down the progression of this eye disease? and what possible side effects come from the disorder itself or from the treatment. Next slide, please. And lastly, I know this will be in our patient toolkit that's coming out. It's just a sort of a worksheet for things that you might prepare before your eye care appointment so that you don't miss anything that you might want to discuss with your eye doctor. So thank you very much for giving me this time to speak with you.
That's such an empowering story and a call to action. Thank you, Tren. We do encourage those who are tuned in live to submit questions at any time during the event using the Q&A box at the bottom of your screen. We will try to address as many as we can during the panel discussion after the presentations. There's also an option where you can submit it anonymously if you would not like to have your identity with the question. Next, we'll have Dr. Layla Lohman talk about her ongoing wellness journey with thyroid eye disease. Welcome, Layla.
Hi, thank you for having me. You can go to the next slide, please. So my journey started in 1998 when I was 14, but I was having symptoms prior to that, about 10, 12, and I was diagnosed with Graves' disease and with exophthalmos, so I was not technically diagnosed with thyroid eye disease. At that point in 1998, I was 14-year-old girl, and my mom and I were just concerned about what was going on with us. And I was on 13 pills a day to suppress the amount of thyroids that were being produced in my body. So the medicine stopped working a couple years later. Caveat this, I'm a twin and I'm a mother of two. So I had such an extreme case of thyroid condition. They checked my twin sister and she had a slight hypothyroidism. So back to my journey. In 2000, my medicine wasn't working. So my two options were radioactive iodine, which had a complication of making my eyes bulge out even further, and thyroidectomy. And those were my two options. So I had a thyroidectomy in 2000, thought everything was controlled because my eyes went back. They weren't protruding as much. And then between 2003 and 2011, I also have allergies, asthma, a lot of other small things that kind of collectively cause super dry eyes, pain, coughing, bronchitis. So I didn't really know what was causing pain. So I just put eye drops in. I did not have a ophthalmologist or just a normal eye doctor. I just went for my routine care, and no one really told me anything until I saw someone in 2008 in dental school when I thought I was going blind because I couldn't see my books. I couldn't see what the professors were saying on their screens. And apparently I just had very, very dry eyes where my tears were actually causing more problems. So in 2008, they plugged my tear ducts and told me, go and get your DDS. And so you can go to the next slide. So I've been battling that throughout my life and didn't even know about TED, thyroid eye disease, until 2015 when I got pregnant with my first child. And I started not realizing with my thyroid condition, you had to be seen by an endocrinologist. I was always seen by my primary care and they've controlled it. But during pregnancy, your first trimester, your second trimester, and your third trimester, you have to change your thyroid medication because it can cause miscarriages and different things during the pregnancy. During my second trimester, I started having double vision, pain, my eyes were protruding out more. And that's when I sought out an ophthalmologist. That ophthalmologist then told me that my thyroid eye disease reactivated, at which point I was pretty shocked because I didn't know I had a thyroid eye condition after the thyroidectomy. I didn't understand why it had happened when I don't have thyroids. So during the pregnancy, he stabilized me with selenium and steroids. And throughout that whole process, my son came early because my health was deteriorating. to the point where I could still work professionally because it didn't affect my downward vision, but I couldn't see straight without double vision, and I couldn't look up. I had severe light sensitivity that, when I was with my family during that pregnancy, I had to turn the lights down. I couldn't watch TV without, doing that to myself. So it was embarrassing, but it's what you're dealt with. My son was born with a rare congenital condition, at which point I blamed my thyroid, I blamed myself, I blamed mom guilt, I blamed a lot of things other than just dumb luck and science. At which point I saw a therapist, which helped me just get better mentally. When we were family planning, I made sure to ask my ophthalmologist how likely would the thyroid eye disease return to an active phase if I got pregnant again. And he said it was very rare the first time. It's even more rare the second time. Obviously, he can't tell me it can't happen. So we decided to try to have another kid. We had some fertility issues, and then I got pregnant in 2019, and my thyroid eye disease reactivated again earlier though. So that was rough. So I didn't have much ability to do anything because when you're pregnant, you can't do much. So we did selenium and steroids again. And then my daughter came early at 36 weeks, son at 35.5. And this is kind of in 2020, 6 months after her birth, they talked about teprotumumab, which is known as Tepezza. And my doctor had been watching me for 6 years, and he finally saw a non-surgical approach to addressing my issues. You can go to the next slide. This is just a side note that I'm always conscientious of my eyes. If you look at the photo on the left, 90% of my photos of me being excited is like my eyes are bulging, and it's tough. And so I purposely squint my eyes because of that. So it's kind of shameful, but I do it. So the journey's been rough. You can go to the next slide for me. So just kind of the impact over life is the disease management was first with pills, and my only option was surgery. Prior to having my son, and after having my son, it was orbital decompression or lid retraction surgery, and both complications came with a possibility of blindness. And so I couldn't be a dentist if I was blind. So we just took the conservative approach of wait and watch. And so we just did management. Throughout that journey, again, I've gone to therapy, mental health, makes me a better mom, wife, everything, a person. So make sure to take care of yourself because that's hard. My career choice, I didn't realize that it had an impact, but it did. I was having pain and discomfort, and I didn't know anything about it during that time. So I'm glad that my ophthalmologist in 2015 finally diagnosed me with something that I could actually be treated. Pregnancy outcomes, double vision, preterm labor, the embarrassment of wearing an eye patch. I have a good support system, family and friends, but they still don't understand that it's a chronic condition. And so it's hard to have them to understand that. So it's nice to have the advocacy groups, which is why I became a patient advocate. Going to the final non-surgical approach of the infusions that I got to have, access to this was really hard because you have to rely on your ophthalmologist to know about the product, to tell you about the product. And so it was the first non-surgical approach in infusions. There was a lot of red tape, even with good insurance. I had to do a lot of pre-authorizations, conversations. I can say that I didn't realize how much pain I was in until I felt relief, which was incredibly amazing because now I have more relief than I have in my entire life. And so I'm very grateful, which is why I became an advocate to tell people the story and to fight for your benefits and talk to people about these conditions. Speaking of the Patient Toolkit, which is the next slide, these amazing women who have put this webinar on and have brought me in to be able to share my story so that people don't feel alone. And I still get stopped in the grocery store saying I have huge eyes, which is still a little hurtful, but if I would have known some of these preventative measures, I would have loved to be able to protect my eyes and my vision more, to continue to wear protective eyewear. It's funny because I have to wear masks at night because my eyes don't close all the way and it causes problems the next morning. So that's very awkward, but luckily I have a supportive husband. Limiting your eye strain. We're all on our phones and our computers a lot, especially through the pandemic. So trying to limit those and make sure you're wearing your sunglasses, using products that don't dry out your eyes for makeup for women, and making sure that you have a good team to help watch when you're in an active phase or in a problem, that you're able to work with them. So look out for that toolkit that's coming on, and happy to answer any questions at the end.
Thank you so much, Layla, for sharing your story and walking us through your journey. We appreciate your transparency. And last but not least, I'd like to introduce Kira Baldonado to discuss the policy implications surrounding eye care and diseases, particularly addressing barriers to access and healthcare implementation. Welcome, Kira.
Thank you, Irene, and thank you to everybody at the Society for convening this session. And I especially appreciate the stories from Tren and Layla that talk beyond just the eye disease and really talk about all of the different barriers and impacts on quality of life that come with vision disorders. I'm going to talk today a little bit about the policy implications and some of the issues around access, but also some of the resources and approaches that we can take to change some of these issues. Next slide. So first I want to touch on navigating insurance. What we've heard so far today is the importance of early detection, getting connected with the right provider, and maintaining treatment. And all of that is wonderful and possible as long as you have the right insurance coverage. And that really does change over the life course of an individual, a woman in this case, as we're talking about today. So in the early ages, there's generally good coverage for children through Medicaid, through general care. But as we get older, your access to vision coverage and related medical coverage can change, whether you have insurance through an employer or you're through public insurance. And then as you get older and advance to Medicare, the coverage for vision can be limited unless you have a Medicare Advantage plan or you have the ability to cover some of those services yourself financially, which is difficult as we all get older. So that insurance coverage for eye care and making sure that we can access providers, get early detection, get the treatment is really dependent on where we are with our insurance coverage, along with a lot of other social determinant factors that we've heard about today. Your awareness of the issue, your ability to get support in your care, amongst a myriad of other things that we've talked about already. So when you're looking at accessing benefits, some insurance companies do require what's called prior authorization for certain treatments. This can also be called step therapy. So this means that if you go to get therapy, an insurance company may require you to have a certain type of therapy first, and then fail on that therapy before you can access the next therapy that's kind of in their progression of available therapies. That first therapy may not be the same one that your eye care provider recommends for you as an individual. So this is a concern. It takes away the patient-provider relationship and what is the right treatment for you at the right time in the right way. So it is a concern, especially when you're talking about vision disorders. If you have to fail first on a therapy, what that translates to is vision loss, in some cases blindness. So it really is important that we're making sure that you are vocal with your provider, what's the right treatment for you, and with their support are vocal with your insurance company, making sure that you have the right coverage for the treatment or medication that's right for you at that time. Next slide, please. So if you go to seek that kind of coverage for the treatment, you may be denied. And so you do have the right to appeal a denied claim. And typically many people do see it overturned as they take action down the road. But again, this is your vision health that we're talking about. So it's important to take action immediately. This is a task that the eye care provider's office typically takes part in. So you want to have communication with your office about the status of your claim and the status of that appeal, and try and get it resolved as soon as possible. Oftentimes, well, we all know when you're dealing with insurance, it's a very difficult thing, no matter who you are. So oftentimes you might want to engage what's called a patient navigator. These are individuals who are commonly in hospital environments or medical environments, and they're there to help individuals through the healthcare system, whether it's setting up your doctor appointments or communicating with insurance about your treatment or an appeal, and offering social support and connection to other services. So if you're not feeling that you understand what's happening or that you feel comfortable with what's happening with the initial conversations, seek out a patient navigator and ask for that service so that you have somebody that can help you along that pathway to care. Next slide. One of the things I want to be sure that we touch on today is that, well, we talk about women experiencing vision problems more commonly than men in those areas we described. Women are also more commonly the caregiver. Up to 20% of the US population serve as a caregiver in some way in either a part-time or a full-time caregiving role. And in the perspective of vision disorder, vision disease, impairment, or blindness, there are a lot of different perspectives on caregiving to consider. The home environment, which may require some changes or some adjustments to make sure an individual can live independently in their home. So a caregiver will probably be helpful in finding those adjustments and getting them made. Making adjustments in daily living activities, which is really critical. Oftentimes when you have vision loss, people start to feel they can't be as active or be as engaged socially or do what they love. So finding ways to incorporate new ways to doing daily living activities is really critical to maintaining that mental health that Layla touched on in her presentation. And then also a caregiver may help in connecting with assistive or adaptive devices. Right now, about 25% of individuals with blindness or vision loss are really utilizing assistive or adaptive devices. So there's a lot of potential for more people to be helped by connecting with this. And so these are devices that help people to read their mail, to read books, to engage with others. And so they're really important to maintaining independence, quality of life, and social connection. Transportation is a big issue in the vision world. As you have progressive vision loss, your ability to drive is often lost. And so it's important to understand what is the public transportation system, what is the opportunity to get assistance with getting somebody to appointments, and that function falls on the caregiver quite often. And then certainly the caregiver helps at the doctor's office, advocating for the right kind of care, asking questions, and providing support and understanding what's being said. But most importantly, we want to make sure that caregivers are providing their own support as well, taking care of themselves, as I appreciate others have said already today. And so there are connections with professionals, with peer groups that are out there. And the wonderful thing is all of this will be outlined in the toolkit that's going to be released in January. So don't just read on the eye conditions and women, but also look at that caregiver role and the resources. Unfortunately, not enough caregivers look for support for themselves. So make sure that you connect with all those resources in there. Next slide. So we've touched on a lot of different pieces that can complicate eye care, eye health. And so certainly there are a lot of policy initiatives and steps that we can take to improve these conditions. Making sure that we build vision screening into regular care for women of all ages is critical. Early detection is the best way to get people to understand what the issue is, get them connected to care, and understand the importance of maintaining treatment. So we have to build vision screening into primary health care, community outreach programs, and other public health initiatives. We also want to watch policies around step therapy and try to limit those, or make sure that the patient's voice and consideration of what's best for the individual is taken into account at all times. We really have to watch those step therapy policy approaches that get hidden into a lot of other pieces of legislation. We also want to establish comprehensive access to basic vision screening and eye care. As I mentioned, in many employer plans does not include vision care, but also as you look at basic Medicare for those individuals age 65 and older, access to a comprehensive eye exam is not a basic piece of that program. So unless you have a diagnosis of diabetes or family history of glaucoma or some other medical condition, you don't have access automatically to eye care and supporting eyeglasses and treatment. So that would be something you have to purchase in addition, but also as a policy change that we'd like to see down the road. And we know folks are working on that. We'd also like to see more women and girls included in medical research. A lot of the standard clinical practices of care for different diseases are based on clinical research that includes largely males. And so they may have different functions and how they work in females. So we'd like to see more women and girls included in research, that we know that we're having the best treatments developed and approved by the FDA that are the most effective in women and girls. And we'd also like to support a strong, diverse public health and vision health workforce. We know that people are more comfortable if they see a professional that looks like them, that sounds like them, that has similar life experiences. So diversity in public health and in vision health workforce is really critical to make sure that people are comfortable with the care they're receiving. We certainly want to see a population health approach given to research so that we understand the barriers that people have getting to eye care. Why are there cultural beliefs around eye care? Are there issues in certain populations over others that can or cannot access eye care? What are the disparities that we see in urban versus rural individuals in accessing care? Where is some disease more prevalent than others? We need to have that surveillance around these disparities to understand how we can get the right interventions that work for those populations. And certainly we need to consider the needs of individuals with vision loss. Right now, you are not able to access items for rehabilitative services for vision through Medicare. That's not something that's covered or even legally allowed at this point in time. You can't even get a white cane if you're blind through Medicare. So the supports for individuals with vision loss is not strong at all in our country, and certainly some policy change needs to happen there. And critically, we need to make sure that we have funding for both the CDC's Vision Health Initiative as well as the National Eye Institute. So we need to know where the problems are through the surveillance conducted by the CDC, and we need to have the research outcomes from the National Eye Institute to have therapies to serve those populations that we find. So there's a lot of work to be done, and certainly something for everybody to contribute to. So I appreciate all of our patient advocates that spoke today and all of you in the audience for being here. That's the first step. Thank you.
Thank you very much. Thank you very much, Kira. We invite everyone to the panelists to turn on their cameras. And as we are preparing for our discussion, it was a great setting of the stage for this next Q&A session. I want to invite participants to use the Q&A box at the bottom of your screen or your device to ask questions. You can submit your questions there, and we will try to address as many individual questions and common themes as we can during this portion, but we may not be able to get to them all. I did want to make a note before we get started that we saw some questions that came in about the toolkit. And so that toolkit will be launched in January, and we will be sending that information out to those who are registered as well. So be on the lookout for that. And it also includes that doctor's visit worksheet as well. Not necessarily for everybody, but I kind of want to open up the conversation with a starting question. What is a personal lifestyle tip that you might offer for women who might be recently diagnosed with an eye condition or disease? And this is, oh, okay, Layla, we can start, and then maybe even something.
And you want to start? No, I'm just kidding. Oh, that was a hard question, because when you first hear that you have it, you are going through all these things of how it's already going to invade your life that's already busy, that you already feel like you don't have time for. So I guess something that I'd recommend for them is maybe doing more research and getting a little bit more support. So if they need to vent about something, they can vent to somebody who can give them advice on, like, yeah, that happened to me, try this. Because when you do that with other people and nothing's ever happened to them, you just smile and nod and appreciate their kind responses. So I think that if you just were diagnosed, obviously I would never Google something, because that's just scary. I would find a professional and or somebody who has gone through it, like the support groups and your advocacies, and maybe just saying like, hey, is there someone I can talk to? I know Horizon's putting a TED like mentor program together for anybody who's dealt with it, because not everyone will be a candidate for that drug. But that way that someone could talk to somebody about it. So I think something like that is what I would recommend.
Yes, I know there are definitely some resources that healthcare providers offer. There are also resources that insurance companies offer, and then some of the individual companies. So there are some opportunities out there. And in our toolkit, we do have some resource links where there's certain support organizations that can also provide additional care and help. Dr. Schomburg, I wanted to transition a bit, and if you could, because, well, and I think even on the patient side as well, this might help. A lot of these conditions that we're talking about have very complex and systemic nature to them. Like, TED and diabetic retinopathy, there's different healthcare specialties that are involved in patient care, and this individualized approach can make it very complicated or unwieldy, I think, from the patient side and from the clinic side. How can providers coordinate to ensure that optimal care is provided?
I think it's a great question. And I think there are certain care systems that enable that type of coordination of care better than others. And so in part, I think it might be somewhat dependent on the particular care setting in which the patient is being seen. And to the extent it might be possible to opt into a care situation where that coordination of care is happening more routinely, that might be of benefit. Otherwise, I think it becomes really can be somewhat of a challenge to ensure by yourself that everything is being coordinated. I don't know if Tren or Layla, you have some other thoughts, but that's kind of what comes to my mind.
Yeah, what strategies did you guys incorporate to be able to manage the different care amongst your healthcare providers?
Honestly, I'm still battling it. I'm sure Tren is also. Like, my endocrinologist, during my pregnancies, acted like it was no big deal, and they would just see me every 3 months and didn't really pay attention to my eyes. And then I'd have to be the advocate to tell my eye doctor, and then they didn't communicate. So that's, I agree with you, Dr. Schomburg. I think a multidisciplinary approach is absolutely the way to go, but it's the providers who don't really communicate, which is the most frustrating part as a patient. And as a provider through dentistry and oral health, my referrals are lengthy and telling everything that we talked about the patient. I contact that doctor, and I had to fight between my endocrinologist, and my ophthalmologist was great. It was endocrinology that was just so busy, and they're just like, your numbers are fine. So it's still a battle. So I just appreciate the providers who do help, but it's something you have to do yourself, unfortunately. I don't know about you, Tren.
I was just going to say, I mean, I've been very lucky, fortunately. I think with the advent of electronic medical records, especially, I have sort of put my ophthalmologist in the role of the person who's absorbing everything. So every time I get a scan for some other disease, every time I get it, he knows about it. So that's how I've been coordinating my care. Obviously, being in the medical field has helped too, so I'm able to fill in, the spaces. But I would just say, whenever you go to get a scan done or go to another doctor's office, always authorize that your medical records be released to whoever have been the most responsible for your care so that they can see what's going on.
Kira, what about you from the policy? How can policy help support this effort?
Well, throughout the conversation today, we've talked a lot about the term advocacy and patient advocate. And I listed a whole bunch of different policy things that needed to change. And I guess I want those in our audience to understand that you don't have to just march right up to Capitol Hill automatically to make changes. There's a whole range of things that you can do to be a patient advocate. So the person that's newly diagnosed can start to take steps now along the journey. I think it's really important to become educated first and foremost, whatever your condition is, become educated about it. So then as you start to speak to others, you have that background. And then, capture your personal experience, tell your story. And that could be telling your story to your smartphone. But just practicing telling your story. What were the key points that made an impact for you? What were the treatments? What were your thoughts at that point in time? And your story may change over time. So, capture it often. And I would encourage people to volunteer with different advocacy organizations. We've heard some listed today. Prevent Blindness is always looking for more advocates. I'll put a plug in there. And we really do want to help patients understand what power their story has, because it's the most powerful voice in the room, whatever room you're in. Help you understand how to shape that story for different audiences and give you opportunities to use your story. And finally, yes, you can go and make change. We've had people who have changed state law because of step therapy, and that was a patient-led initiative. We've had patients raise their voice and change issues around manufacturing of treatments to make sure that they begin again. So the patients have powerful voice. And there's a lot of different ways you can use it. And there are people there that are really interested in helping you do so.
Thanks. That's a great summary. And so even on that, we have to use our voices in so many different spaces and, in the doctor's office, but I've heard you both touch on in your stories, Tren and Layla, about work and school and the complications there. And so maybe can you touch on a bit what experiences, because we know that women experience absenteeism, of course, missing work, but then presenteeism where you're there, but not able to be as productive as you need to be because of the challenges that you're facing. And so how did you handle various disruptions in your educational work, your pursuit of school, or on your job? How did you manage that, or how do you manage what things that you find were successful?
I can speak to that first. I mean, I think I have always been very open and forward when I interview for a job in residency. Most of my issues started particularly after residency. So it was mostly while I was getting jobs or interviewing for jobs. And I would say, look, I would love to work for your organization, but I do have this disease that I have no control over. I'm doing everything I can do. I potentially may need surgeries and may need to be out. I think that if they value you as an employee, don't be hesitant to speak up and just say, I need some of this time off. And I think sometimes when you upfront say it, then they're able to factor that into their decision of, will you fit in with their personnel? So, and it has worked out very well for me. I have a very nice setup right now where nobody is impacted. Patients will be taken care of if I'm taking time off.
Honestly, on mine, I didn't even know I had the problem. During growing up, I just thought I'm a Persian, I have big eyes, I have allergies, and this is normal. And so I guess what I would just recommend is, like, what I'm learning is if you have this condition, go to your professional, go find an ophthalmologist. And what I do now is I'm very honest with my patients during my pregnancies. They were laughing and they were just like, can you see my tooth? And I'm like, absolutely, there's not two of them. So, I mean, humor obviously helps with that. During the studying, I just thought it was normal. And so I think normalizing that conditions are there is going to be what's going to be helpful for girls who just think like, man, I have dry eyes, like I have pain. Like you just think that sometimes you just think that you're just, I don't want to say dumb, but you're just like, okay, I just can't get this. Like my head's doing it, but you don't realize that it's a condition that's like causing your brain to be tired and fatigued. And so just stop being as hard on ourselves. And if you do have something, and if you do like feel something, don't think it's normal, just go get checked. And like when you see Tren or Debra or anybody, just tell them what you feel. And if they say that that's normal because that person doesn't know about that condition, then go get a second opinion. It shouldn't hurt someone's feelings.
Debbie.
Irene, yeah, if I can just, I think, emphasize that second opinion, because I think that it's really empowering for people to, and I would suggest a second opinion in a couple of different situations. One is if you're not sure or you're not confident that you've gotten to the bottom of it. So like in Layla's case, there were just these ongoing things that she didn't have a diagnosis. I think the second time that I would recommend a second opinion is if you're just not feeling a strong relationship with your doctor. And this goes to that coordination of care and somebody really being responsible and just attending to you and your needs as a patient. And sometimes it's, it's nothing against the doctor or the patient. There's just not a good match for, how they approach things. But I would encourage people, if they feel that, really maybe to try to seek somebody that would be a better fit for them.
I also wanted to add, frankly, a good doctor is really never insulted, I think, by a patient asking for a second opinion. My own glaucoma specialist always encourages it. And it's not because I don't trust him. He is fabulous. I owe everything to him, but he just says, it's just more information. It's doing due diligence. This is your vision. This is your health. So find out everything you can find out before you, settle on something.
I had a question for Kira. You spoke about, opportunities and people to help you. And I'm sure many people feel this, but like when my drug was basically stopped because of Operation Warp Speed, I just sent out like 30 emails. And so I just was like, this is absurd. Like, how do you guys determine this? So how does somebody who doesn't know that they have their voice matters, which I didn't know, and I didn't even think this stuff was real. I thought this was movies. And so how does somebody get involved with that? Like you said, that there's tons of people who want to help. They want to hear these stories, but how do people know where to go?
I would say, start with any nonprofit organization that has a connection to your condition, your population that you identify with, and say, hey, this is important for me. I'm experiencing this. What steps are you taking, or what steps can I take with you to help raise this issue? And together you should sort of create a little plan to say, hey, here's the opportunities, here's who we can talk to. We can do congressional briefings, we can go talk to legislators, we can talk to manufacturers, but don't expect that you as the individual have to know all the answers. The only thing that you have to know is your experience and how it's impacting you, and be willing to talk about that with others. That's the most important thing that an individual can do that has a condition.
Thanks.
There definitely seems to be this theme of, assistance and asking for help. And I know it can be very challenging in today's world because we want to be so independent, and women are used to taking care of so many different things, multitasking, managing, everything. But even to that extent, women often are caregivers, but for eye health in particular and vision impairment need caregiving. And I just wanted to kind of transition or open the conversation a bit there, if we can kind of speak to that. And maybe Care, for you to start, what are the resources or what does that look like? Because I know there's formal caregiving where you can hire, but then there's informal, which is usually individuals, friends, family in the household and stuff like that. And the importance of having a caregiver or seeking that assistance.
Yeah, that's the most common actually, is that, there are people that fall into different roles of caregiving, whatever the family or personal situation is. I guess the thing that I want to encourage is that whoever is in that caregiving network talk to each other regularly. You may start out with a plan of, hey, here's how we're going to take care of our mom because she has age-related macular degeneration. But things change over time. So come back together, talk, see how things are working, and, like everything else, evaluate and reset, change things. But that needs to sort of be rechecked over time to make sure that there isn't any one stress on one person over another. But a lot of the issues that come with caregiving come because there's lack of conversation, lack of asking for help, or lack of sharing. So I think when we get into these situations, whether you're an individual with a vision disorder or you're a caregiver, we all need to learn to kind of speak up and be a little more open with our feelings to avoid hurt feelings or anger down the road. And again, I just can't encourage this enough because I hear it time and again from the caregivers we work with. Things change over time. So it's not just how you're doing as a caregiver, but the caregiver should ask the individual they're helping how they can be most helpful now, because the assistance the individual needed at the start of the condition may not be needed now, or may be different than what they're now. So always checking in, sharing, and talking is the most important thing. And find your community. There's lots of communities out there, so definitely find your jam, find your community, and talk with them.
And Dr. Schomburg, I wanted to touch, what does that look like in the healthcare space, interacting with caregivers? What advice would you give to either other providers or to caregivers that want to engage and help when they show up in the clinic? Like, do they need to be there? And, questions, because it's always, you might be there and you want to help, but what does that look like? Or what advice could you give in that, as far as when they are now seeing their provider?
I'm not sure if I fully understand the question. So forgive me if I'm not answering what you're asking. But I think for most providers who really have a focus in a particular disease area, there's often actual engagement, even of those providers, with some of the same nonprofit organizations, the same patient advocacy groups, the same. So, particularly for something like thyroid eye disease or, something like that, where it's seek out a provider who really has expertise in the area and a passion for taking care of patients with that disease.
Okay. And so I guess that's actually really good note, like someone who has a passion for the disease, because then they're looking at it from just a different lens of interest. But, and just briefly, I guess what I was getting at or wanting you to speak to is, what does that look like in the space? Because I know it's sometimes for me, I want to be able to advocate, but if I'm there, I also want to make sure that the person that I'm assisting gets their questions answered. But then sometimes you may not be able to ask the questions or be there if they're not around. So I guess, what does that dynamic look like with the caregiver, the clinician, and the patient themselves? Like, what advice can you have to make sure that that's a smooth conversation or visit or engagement of support?
So you mean with the caregivers?
Yes.
Specifically? I think in that case, there are a couple of different ways, and I don't know, Tren, maybe you have some thoughts there, but I think that at least when I was seeing patients, and I'm not seeing patients anymore, it's sort of a patient permission to give me permission to speak with the caregiver. And once I have that and I understand what I'm able to share or not share with the caregiver, then that becomes a very important part of my care of the patient as their doctor, is communicating. Because a lot of times too, when we're dealing with some of these conditions, there's a lot of information thrown at the patient in a single visit in a short period of time. And if the caregiver is there with the patient, it can be extremely helpful as a knowledge retention person as well, because it's difficult to keep all of that knowledge that you were provided, at the visit. So I think there's that component of ensuring that your doctor knows that you have a caregiver, who that caregiver is, and that you'd like them to communicate with that person, I think is maybe one of the key factors there.
So being more intentional about identifying who that is,
Yeah.
and bringing them to your doctor's attention. Okay.
Mm-hmm.
Yeah, I would echo what Debra said. I mean, when I have patients come in and unless they have some cognitive impairment and won't understand what we're talking about, I certainly want to ask them first, what are their goals for the treatment? What are their goals for their life, and if they're able to voice it, that's great. And I proceed as though they're really the only ones there, and the caregiver is more just an extra earpiece processing the information. And I don't necessarily talk to the caregiver, but in other situations where it looks like they're always looking towards the caregiver, then I will try to find out the dynamics between the two. Is this a live-in caregiver? Is this somebody who's just there for a few hours a day, and figure out how much support does this caregiver provide, and what kind of questions I can answer for the caregiver so that they can provide the care appropriately.
That's actually, thank you. That's really good, because I think sometimes we think it's organically going to be understood, and it's not necessarily obvious. Like you said, you have to find out what their dynamic is, and then you have to do a lot of, deducing as the physician to see whether or not who you should be engaging. So thank you for that. We do have about 2 more minutes. So I want to do a closing question for everybody. And so, given our public events at SWHR attract diversity of patients, we have researchers on here, we have clinicians that tune in, policy professionals, also industry professionals as well. What is a takeaway that you would recommend to viewers from your vantage point to help them support and improve eye care and disease for women, patients, or caregivers? So what is a takeaway that you would like to leave somebody with? It can be any of those particular audiences or just a broad one. And so I guess we'll start with Kira. She always is just prepared with her answers. So we're going to start with Kira.
Wow, the pressure, but hey, I do have an answer for that.
And then we'll do Layla, Tren, and then end with Debra.
I do have an answer. I'm going to take the easy out though and do a broad approach and say that everybody has a role in improving eye health for women, whether you're an individual and you can help change some dietary habits or eye protection habits, to patients to speak up, or caregivers to help support, to clinicians to encourage women and girls being in research, or individuals who are going through education to be a part of that diverse workforce that we need down the road, or companies that are working towards treatments and solutions to listen to individuals and what's going to work best for them. Nobody gets an out here. We all have a role to play in improving eye health. And if you don't think you have a reason yet, just wait. You're going to have an eye health condition down the road that will impact you or a loved one. So it'll come soon.
Thanks.
On my end, I'd probably say exactly what everyone's been saying is, I think talking about it is important. I think letting people know that you're not alone, especially women who tend to hold it in, and shame and pride, and all that goes out the window when you have a condition. And fortunately for us, we are caregivers, home givers, child bearers. We're doing everything we can, working mom, non-working mom. So we all just try to act like everything's okay, and it's okay that it's not. So I think normalizing that it's not okay is okay, because you can have support. So for women, like she said, get involved. And for people like me who didn't know that this TED was common, just kind of talking about it, like you said, talk about your story and just be open. That's what I do with my patients about it. And they tend to feel more comfortable. In Debra's case is, when they get a second opinion, feel comfortable with who you're with, and it doesn't hurt anybody's feelings to change the person, change who it is, and just be open about it.
Well, I think my message is get eye health, get eye care, because don't wait until you're old. Don't think there's some magical age after which you develop eye disease. It can come on at any time, and you don't want to lose your vision, because in most cases, what's lost is lost forever. We don't have a way to restore it. So be proactive, talk to your doctors. Any changes, go even just to an optometrist just to get that baseline check.
I was going to say exactly what Tren just said. I think for me, I'm coming from a public health background, and the emphasis I would give is on prevention, and prevention for the women themselves, prevention for their children and their families. I can't emphasize enough the importance of getting tested, getting an eye exam, going for those exams. If you have the option through your employer of the vision part of the insurance, maybe think about opting into that, which then if you are lucky and you don't have an eye condition, it's still covered, the eye exam, just for a routine eye exam, for example. And then I think I would emphasize the other two public health things, which is really just about healthy lifestyle and not smoking. And we know that those are important for prevention of or delay of onset of the age-related eye conditions.
Thank you so much. I think these are amazing nuggets. You have been a wonderful panel, and to help build this awareness and let us dive a bit deeper into what we can do to support women as they are on their eye health journey across the lifespan. So thank you so much for your time and insight. I'd also like to thank Horizon Therapeutics for their support of this public forum and SWHR's eye health program. The Society for Women's Health Research plans to do much more work in the women's eye health space, and SWHR maintains independence and an editorial control over our program development, content, and work products, but we cannot do any of this without the expertise and contributions of our science networks, particularly the Eye Health Education Working Group members who contributed toward the development of SWHR's Patient Toolkit, a guide to women's eye health. We look forward to launching this resource for the public in January 2022. We will be sending out an email with a recording of today's webinar to all registrants, as well as a toolkit once it's available, so please be on the lookout for that. And to all those who are watching, we invite you to connect with us on social media and visit our website, www.swhr.org, to download our women's eye health and other resources, and to sign up for our newsletter. Lastly, we encourage you to continue this very important conversation using the hashtag SWHR Talks Eye Health. Thank you for joining us. Have a wonderful rest of your day.